you who have joined. This is the second episode of the Journal Club, which is being hosted by the West Bengal Academy of Pediatrics. So as we discussed in the first episode, we are constantly bombarded by multitudes of articles from many journals of different qualities, of different types. And it is sometimes very difficult to understand which ones we should take seriously and which ones should change what we are doing in clinical practice. It takes a long time for these journal articles to translate into guidelines. And as you have seen recently, guidelines also seem to change from time to time with the current evidence. So what we are trying to do is all together, this is something I think that we are all on a sort of a learning experience. We are trying to understand how to analyze these articles critically so that we understand what is good evidence and what is poor evidence, and thereby we understand how much of this evidence we should inculcate in our regular clinical practice. So I'm very grateful to the teams today who have decided, who have agreed to take up the challenge, and we have 2 articles for you that will be analyzed by them. And I really look forward to active interaction from the August audience that is present with us. We will start very shortly. Can I ask Dr. Obhijit Dattur, our academic chairperson, to say a few words? And then Indranil, our secretary, if he is present also. So, Obhijitda, if you will say a few words before we start.
Thank you, everybody, for joining in the second edition of the Journal Club. And I must thank the other members of the scientific committee, particularly Shom Shubro, for giving such effort for conducting this Journal Club. So, and the topics are very interesting. And with the respective specialists of the 2 topics, they are in the faculty also. So I think there is a very fruitful discussion for all of us. Over to you.
Thank you. Obhijitda, are you here? Sorry,
Yeah.
Indranil, are you here? Indranil? I think he has not joined, so he could probably talk later on. Shom Shubro, with your permission, shall we start? Okay, so the first presentation is from Dr. Deblina Dasgupta, and the moderator for this first article will be Dr. Shubhankar Sarkar. Deblina, if you could share your slides and please start.
Yes, ma'am. Am I audible, ma'am?
Yes.
Okay. Okay, are my slides visible, ma'am?
It's coming, just wait.
Not yet, it's just coming up. And also, while we are getting ready, I would request everyone to keep yourselves muted if you're not talking, please. Okay, we can see your slides now.
Yeah, now is it visible, ma'am?
Yes, clear, but if you could go to slide share mode. You had it in the slide share mode a little while ago, but now it's in the normal PowerPoint mode.
Dr. Deblina, মনে হয় নেটটা কাজ করছে না, স্লো যাচ্ছে।
Okay, done. ঠিক হয়ে গেছে। চলো শুরু করো।
Okay.
দেবলীনা, তোমার কাজ করছে না, মাইকটা বলুন।
নেটটা প্রপারলি কাজ করছে না, নেটের প্রবলেম আছে, নেট কানেকশনে।
Published in
unmute yourself.
Deblina, you're muted.
Deblina,
Mute,
unmute
mute.
yourself. Okay.
Yeah. So I'm going to discuss the river.
তোমার স্লাইডটা এখন নেই।
এবারে আছে ম্যাম?
No. Are you on two different devices?
No ম্যাম।
স্লাইডটা তো এখন নেই।
আরে শেয়ার করো, শেয়ার নেই ওটা।
ম্যাম অ্যাকচুয়ালি আমি শেয়ার করে রেখেছি। আই উইল ডু ওয়ান থিং, আমার এখানে না জুমটা বারবার ক্র্যাশ রিপোর্ট আসছে, আমি একবার লগ আউট করে আরেকবার লগ ইন করছি।
If তাহলে যদি দেবাঞ্জন রেডি থাকে আমরা কি সেকেন্ড আর্টিকেলটা আগে করি? দেবাঞ্জন, আর ইউ রেডি?
তুমি আমাকে ইমেল করো না স্লাইডটা একবার।
Yes, ma'am.
ওকে, why don't you start? তুমি নিজেকে একটু ইন্ট্রোডিউস করে দিও, তারপর শুরু করো। হ্যাঁ, শুরু কর। তো share your screen.
Okay, I'm introducing Devanjan. Will I proceed?
Yes, please.
Okay, thank you.
In the meantime, if Debanjan could start sharing his slides.
Yeah, because there's some problem happens with this time of sharing. Okay, Devanjan is going to present a wonderful article. Basically, it's a big trial. The name is Rhino trial. This trial is actually aimed at finding out the causes and steps that could be taken to minimize or to improve the outcome in preterm born children who are having decreased FEV1 or decreased spirometric scores. So this trial started in the year 2013 at UK, and it's an ongoing trial. It's still continuing now, and it has 4 phases. Now, our presentation will be on phase 1, that is inhaled corticosteroids alone or in combination with a long-acting beta receptor agonist, the LABA, to treat reduced lung function, all those preterm-born child. The study has a 3-arm, it's a 3-arm trial. It's a beautiful study. They have done it very well. Of course, obviously, there are certain things we will discuss in our critic section. So without spending much time, I am handing over to Devanjan.
Hello. Very good evening to everyone, all the respected panelists, and thank you West Bengal Academy Pediatrics for giving me the opportunity. Today our topic of presentation, the journal, inhaled corticosteroid alone and in combination with long-acting beta-2 receptor agonist to treat reduced lung function in preterm-born children. It's a randomized controlled trial published in JAMA Pediatrics, February 2022. So as Sir already described, original trial is Rhino trial, and these are the identified numbers, sorry. And it was published in JAMA Pediatrics with impact factor 16.2. They have already mentioned the publication date, open access and corresponding authors. These are the conflict of interest that disclosed, funding and data sharing all disclosed. So first one is the title. Since it is a randomized controlled trial, we have to analyze with the CONSORT 2010 extended checklist. So here the title already satisfy the criteria, and the research question is of the trial is, can inhaled corticosteroid alone or in combination with long-acting beta-2 agonist improve the percent predicted forced expiratory volume in 1 second compared with placebo? So here is the abstract of the study. So their objectives in the abstract were whether 12 weeks treatment with ICS plus LABA or ICS alone can improve the spirometry and exercise capacity among school-aged preterm children with FEV1 less than equal to 85%. So it was double-blinded, double-dummy RCT with placebo-controlled, a total 144 preterm-born children from 7 to 12 years age with gestation of the birth less than equal to 34 weeks were included from July 1st, 2017 to August 31, 2019. And they were randomized in the 3 arm of the cohort. First arm got the inhaled corticosteroid alone, that is fluticasone propionate 50. Second arm got fluticasone propionate with salmeterol, that ICS plus LABA, and third one got placebo. So their basic result were like among 144 preterm born children who were identified with less than 85% FEV1. Among them, 53 were randomized, and they were adjusted means for fractional FEV1 with analysis of covariance with ICS plus LABA, and placebo. So they concluded as the result of this trial suggests combined ICS plus LABA treatment is beneficial for the prematurity associated lung disease in children. We are going to the main article right now. So in introduction, actually they wanted to say that preterm birth is known for the lot of significant risk factor and mainly lot of the lung injury, mainly bronchopulmonary dysplasia. But there is lack of data on how to treat beyond the infancy and after that to overcome the respiratory difficulty in the later on. So there is also lack of data to establish the efficacy of bronchodilator or ICS to treat such patients to improve the spirometry. Their primary outcome was pre-treatment and post-treatment difference of FEV1 analysis with ANCOVA analysis after 12 weeks inhaler intervention in the three groups, the three arm of the trial, and secondary outcome were changes of other spirometry measures, exercise capacity, and fractional exhaled nitric oxide level before and after inhaler intervention. So they satisfied the consort trial guidelines of scientific background and scientific objectives. Now, original aims of the trial were to establish whether there is any underlying mechanism of chronic airway obstruction in symptomatic preterm-born children and identify any different phenotype to respond any standard therapy. And primary objective were whether ICS and LABA modify underlying mechanism and improve outcome. And secondary objective was to obtain repeat posterior assessment for long-term respiratory and neurological outcome. So identify the mechanism of airway obstruction, whether it is due to atopy or inflammation or structural abnormality or bronchial responsiveness or any genetic issue, and to study the pulmonary structure and function by hyperpolarized gas MRI. So participants were those who satisfied the FEV1 percentage less than 85 with using 2013 questionnaire study of the Rhino trial. They included with gestational age less than 34 weeks as birth history and the age group of 7 to 12 years children, while they excluded the severe congenital anomaly, severe cardiopulmonary anomaly, and neurodevelopmental impairment. They recruited, as we have discussed, that July 1st, 2017 to August 13, 2019 at the Children's Hospital of Wales in Cardiff. And outcome were pre-bronchodilator, percentage of FEV1 less than or equal to 85% were invited to the randomized control trial, including the spirometry, exercise capacity testing using cycle ergonometry, pheno assessment, and screen prick testing. And neonatal course recorded regarding the BPD and lung impairment with neonatal medical notes. So there were the three arm of the trial, one with fluticasone propionate 50 with placebo, next one fluticasone propionate 50 with salmeterol 25, and third one with placebo. Here I want to mention one thing: they have not used any combination of inhaler. So they given first trial, which was ICS plus only ICS, one inhaler of ICS and one inhaler of placebo. In the ICS plus LABA arm, they given two inhaler, one of ICS and one of long-acting beta agonist. And the placebo arm, they have given two inhaler of placebo. So they were undergone 12-week treatment with given arm and monitored. Adjusted pre-treatment and post-treatment difference of FEV1 were analyzed with ANOVA, and intention to treat analysis was conducted. So this is a bit of cycle ergonometry. They have used 1 minute of baseline measurement at rest, increasing rate of 1 watt every 6 seconds, 3 minutes of minimally loaded cycling at about 7 watts, and while there was 2 minutes of minimally loaded pedaling, that concluded the test. This is actually the exercise which were used for analysis pre-exercise and post-exercise FEV1 in the each of the arm. And before going to this exercise cycle ergonometry, they have instructed to stop LABA for 48 hours visit, ICS for 24 hours, short-acting beta agonist for 8 hours, leukotriene receptor agonist for 48 hours, caffeine for 24 hours, antihistamine for 48 hours as shown. So this is the consolidated standard reporting trial as mentioned in the article. As mentioned in the article, 144 preterm born identified from the home. First, identified from the home, 144 with FEV1 percentage less than equal to 85. From there, 57 were excluded. 53 due to unable to contact, 3 were not suitable for weaning from ICS, and 1 was unsuccessful to wean from the inhaled corticosteroid. So 144 minus 57, we got 87 for the initial formal assessment. And among the 87, 37 were excluded due to FEV1 more than 85% and 4 inadequate spirometry. So we got actually 50, and here 3 were additionally added from the preterm control, so that we got the sample size as 53. I am going to next slide for how they calculated the sample size. So they are with ANOVA, one-way ANOVA, sample size was around 55 to 60. So they actually added 3 from the preterm control to get 53. And after 53 randomization, they allocated in the 3 arm. 20 in the, actually there is printing mistake in actual JAMA website also. So here it will be 20 in the ICS alone, 19 in the ICS with LABA, and 14 with placebo group. And among 20, first arm, 2 were withdrawn. So we ultimately got 18 for the complete second laboratory visit, 2 withdrawn, and ultimately got 17 for complete second visit with ICS plus LABA. And from the placebo arm, we got 13 for who completed secondary laboratory visit. So this is the CONSORT actual 2010 flowchart diagram, where we have to go for the enrollment, allocation, follow-up, and analysis, and they have properly maintained all the category. So this is actually the main algorithm in the Rhino trial, because for randomized control trial, there is also term control and preterm control. So I'm going for the original Rhino trial that is available in the supplement 2, not in this article actually. So here, initially 7,000 patients, 7,000, they actually sent for the questionnaire with 4,200 preterm and 2,800 as term. From there, we have applied, actually they have applied the inclusion and exclusion criteria, and among from 7,000, they got 1,000 for home visit. So after the home visit, those whose FEV1 more than 85% went to the control arm, both term and preterm, and whose FEV1 were less than 85%, they got to the actual RCT trial, which I have already mentioned. So among them, they got the 3 trial, ICS plus LABA, ICS, and placebo. So 60 were in the preterm control, 20 in the term control, and 20 in the preterm control. This is the final RCT trial flow diagram of the original Rhino trial. So statistically, they were actually randomized as initially children who were not on corticosteroid. They were allocated as 1:1:1 in the 3 group, placebo plus placebo, ICS with placebo, and ICS with LABA. But the patients and the children who were on corticosteroid, they cannot be put on placebo. They the original author already mentioned, because ethically we cannot put them on placebo. So they made it as unequal randomization as 1:1.3:1.3. And sample size was calculated with one-way ANOVA, I have already mentioned. And the data and analysis with strata 15, p-value less than 0.05 taken as a significant value. And the adjustment of the multiple comparison were with Games-Havel method with ANCOVA analysis. ANCOVA were used in accordance with our predefined statistical analysis with US FDA and the European Medicine Agency. And in the ANCOVA model, data were adjusted for sex, gestation, BPD, intrauterine growth restriction, and other prenatal factors. So these are the CONSORT guidelines of methods, and almost all criteria they have fulfilled. And in results, these are the demographic profile of all the patients of the 3 arm. And here nothing got very much significant of value. And in pre-treatment and post-treatment group, here we have mentioned in the 3 arm with pre-treatment and post-treatment, that is after 12 weeks of the treatment in each arm. So we got the fraction of the FEV1 was significantly increased in ICS and more increased in the ICS and LABA. And other spirometry parameters were also significantly increased in the ICS and LABA groups. And while FeNO is decreased in these groups, while it is not decreased in the placebo group. These are the adjusted mean spirometry measures in 3 arms with corticosteroid naive and all randomized children. These are the flow diagram they have described. Here we can see this is the ICS arm, this is the ICS plus LABA arm, and this is the placebo arm. In the ICS and LABA group, there was significant increase after the post-exercise and post-exercise bronchodilator use with percentage of FEV1. So results were almost satisfied all the criteria of the consort guidelines. And summary of the trial result were 12-week treatment with both ICS and combined ICS plus LABA improved spirometry in preterm born children with low lung function compared with the placebo treatment. Treatment with ICS and LABA resulted in significant improvement that were additive to ICS treatment alone. The FeNO decreased after both active treatments, but not after the placebo treatment. And neither active treatment affected exercise capacity, but post-exercise bronchodilator response in the ICS and ICS LABA arm at the pre-treatment visit were significantly less at the post-treatment visit. So current results showed that FeNO decreased from 29.8 to 15.8 parts per billion in the ICS group, while it is ICS and LABA group, it is 25.2 to 15.9. So these are the significant data. And it can show that there is significant effect of inflammation, because in research question, they want to establish whether inflammation, what is the factor actually, because preterm there is lung injury, why they will be in the later on after 7 to 8 years, they are going with the lung problem. So it might be inflammation play a significant role. That's why ICS, inhaled corticosteroid and long-acting beta agonists were helped to improve the spirometry result. So summary of the similar study results as shown that European Respiratory Society Task Force highlighted the lack of evidence how to treat the respiratory problem thereafter the childhood and infancy period who were undergone BPD treatment. And one study by Khan and Silverman studied 15 children in 1993 with low birth weight. There were significant factors: low birth weight 2,500 grams, including 10 weighing less than 1,500 grams, who had airway response to aerosolized histamine. They used aerosolized histamine in a 4-week crossover study with beclomethasone dipropionate twice daily. No improvement from baseline spirometry noted. 2001, one study also mentioned as budesonide 400 microgram twice daily 4 months among the 21 preterm born children. With 18 children completing the study, baseline spirometry measures did not improve in their study, but bronchial ability improved with the treatment. There were no improvement in exercise capacity after the treatment with either ICS or with ICS plus LABA combination in their study. So the author mentioned as strength of their study were to clear benefit of using combined ICS plus LABA in preterm with the lung disease, and they have used percentage of FEV1 so that it can be easily used in outpatient of any general practitioner office setting. And they have mentioned as limitation that larger number of patients need for more significant result, and only the children using ICS were randomized and may produce some treatment bias that I have mentioned in the unequal randomization. So that is also followed the discussion and other information criteria of the consort line. So here is the critical appraisal time, and we must mention that their study is very good and very methodical study for randomized controlled trial. However, main issue were the unequal randomization, because those are children who may not need the ICS due to randomized controlled trial because they want to actually prove the fact whether inflammation is the main key role for preterm injury to the long-term injury. So who enrolled in the ICS or the ICS LABA group, they might not need it. That might be due to different factors, but it may be one effect. And similarly, they have those children who were used ICS previously, they have included in the 2 arm, either ICS or ICS plus LABA. They cannot be included in the placebo due to the ethical issue. But it is one fact that should be overcome with other method of the study like cohort, prospective cohort, or some case control study. In longitudinal follow-up, it must be needed for whether any other association can be done. And they did not consider asthma or any hyperactive airway disease, which can also reproduce the similar result in the term birth. They mention as preterm birth as less than equal to 34 weeks. They have not mentioned the different gestational weeks, because if the preterm or any newborn born less than 26 weeks, they have different respiratory development problem or different lung insult than who are getting born by 33 or 34 weeks. And similarly, late preterm age after 34 weeks is not also included and categorized in this chart. Other leukotriene receptor antagonist, whether a different type of long-acting beta agonist is useful in this to improve the therapy, that is also not included. Whether leukotriene receptor antagonist and other modality of treatment is also not included in their study. So thank you. This is all about the Rhino trial I have discussed.
Okay. Thank you, Devadun. You have made a very good presentation. Now, with permission with Shushmita Madam, we are entering into the question and answer session. Hello.
Yes, there are some questions in the chat box as well as in the question answer box. Can you see them?
In question answers, one sent by Shuman Raut.
Shumantra Raut.
No, it mentioned
हाँ,
it's written
Shuman,
Shuman Raut.
it's
I think it's our Shumantra.
Yes.
What was
Yes.
What was the presumption of success rate of FEV in 3 limbs pre-study from prior uncontrolled or single limb study? Was those magic numbers considered during sample calculation of RCT? What was the presumption of success rate of FEV in 3 limbs pre-study from prior uncontrolled or single limb study? Was those magic numbers? I think Sir is asking about how I got 20, 19, 14.
How the sample size was calculated based on some previous study?
No, I think whether he's asking for the FEV1 that is less than 85%. Shumanto, you can directly speak.
I think Shumantra will have to be made. Shomnath, Shumantra ke panelist korte hobe.
No, he can just unmute and talk to us directly. I think the definitely
he's in the audience. He's in the audience.
Oh, audience cannot directly talk.
No, audience cannot speak, huh? Only listen.
Okay.
And the second question, I think you have already mentioned. How can patient and ICS be blindly randomized?
Yes, ma'am.
So
that is actually unequal
randomized.
That is not unequal randomized, because the patient who are on ICS, they cannot be put on placebo group due to ethical reason, a definite ethical reason. There might be adverse effect or the patient might get worse during the trial, so they could not place on equal randomization.
And Mayadi has asked, is it justified to give placebo in low lung function cases? So those ones, there was a control group even in the patients with low FEV1. Do you think that was justified?
No, that is also not justified. But their study, actually their objective and research question of the study were whether what is the factor that is actually playing role from from preterm lung injury to the adult lung problem. If there is inflammation is the key role that they have already analyzed, their inhaled corticosteroid, that steroid will act. But if inflammation is not role, suppose if atopy or the immunity is the role or any genetic issue is the role, inhaled corticosteroid might not act. So I think in that issue they wanted to
no, I like to add also to my madam's question that though on spirometry they found that it is less than 85%, but they are all clinically stable child, and of the entire population, 85% who though having on spirometry low lung function. That is, look, like this, many of us who are having low lung function that is to be detected on examination, but otherwise we are
But
moving
not
well.
symptom.
Not
So that's a
asymptomatic.
very important question. How many of these patients were actually symptomatic? Were they just picked up on FEV1 findings alone?
I'm just telling you the
or-
entire process of selection. Initially, they sent letter to 7,000 households, of which there are 4,000 preterm and 3,000 control term, and they just seek permission from their parents whether you are interested to participate or not. Now, of them, 1,000 have agreed for participation. So the team went to their house and they did the spirometry, their demographic study, their anthropometry, and so on, so on, so on. And once they found that they are having lung function FEV1 less than 85%, look, this is one point that is some sort of bias in the study also, that suppose one day due to some reason you can have a FEV1 low because maybe the child is a bit ill on that day, or the child has a sudden some sort of problem, so may not be able to perform the test. So that actually happened also, that in the later part when they are going to the main study, they again do a FEV1, they found that many of them had actually FEV1 more than 85%. They are experts on the study. And also it happened in the control arm that somewhere were having FEV1 more than 85% initially, they are having during the study less than 85. So they are again doing the study. So this is some kind of bias that happened.
Okay. But there, it is not mentioned whether they were actually, there's some of the children were already on inhaled steroids. That means they must have had, some of them must have had some symptoms.
Yeah, 15%,
already.
15% children are on inhaled steroid. Their steroid was washed out, and they are placed on ICS or ICS and LABA, but they are not placed on placebo.
I think this question from Dr. Ashok Modi is very interesting. Is there any mention of how many of the children actually had major lung disease and followed by BPD?
Yes, initially, Devanjan has showed a chart. That is a prior test. They have a chart which is there is the mention that how many of them had the BPD. That chart was shown by Devanjan at the initial part. That is prior to onset of the trial.
Okay.
Yeah. BPD mild just to shown, sir.
3 arm we can see which
BPD mild,
mild, moderate, 1 and 6 in the first arm.
They all collected this data from the previous birth history in this way. So is it possible only in UK, because they have all the data they collected? Now they met a child at 7 years and they have collected data at the time of their birth.
True. And it also makes you think that if they have, these children have low FEV1s when they are 7 to 12 years old, no?
Yeah, 7 to 12.
Then would having treated them much earlier have improved this outcome?
Actually, they are asymptomatic. That's the reason. So they were asymptomatic and they are not. Patients were not aware that we'll go, and because if there's a guideline, just like say for UTI, have a lot of guidelines. You should do this and that, then after that or that. So there was no definite guidelines how the child with BPD will be follow up in their future. So this team is actually in the process of this building up this guidelines.
Do we have any more intensivists or neonatologists here? Any further questions? Dr. Jayati Sengupta wanted to see the chart of the results, I think. And any more comments?
I have a comment to make.
Ogni, go ahead.
Oh, sorry. Yeah, am I audible? Am I audible?
You are well audible.
Yeah, something very interesting here about which they have not really mentioned, and I think they should have mentioned it, is if you look at the mean gestation, then the ICS plus LABA, their mean gestation is almost 31 weeks. Okay, whereas the other groups, both of them are sort of 29 plus 3.
29 plus 3, 29 plus 2.
And that is the big difference actually. And that is the reason why if you see at the birth weight, their birth weight is appreciably higher than the other two groups, especially the ICS group, 1535 against 1243. And even with that higher weight, the percentage of IUGR is actually higher in that group, simply because their gestation is so high. And that is a big difference actually, and that they have not mentioned. I think that should have been mentioned, and that actually brings into question how they have randomized it. Because if the randomization was proper, then this should not have happened. Or I mean, it can happen if you are unfortunate enough. And then
But
I have
you know,
looked.
Agni, they have
Yeah.
not given the significance values for these. I am
No,
assuming
and
that these were non-significant
no,
differences.
no. The thing is, if you are randomizing, then some people give p-values, but actually, statistically, it makes no sense because you have already you know that it is a randomized sample. So it has happened by design. It is by chance. Actually, many people say that when you are randomizing, then the difference between group allocation, you should not compute any p-value. Because by design they are random. If they are random, then why calculate p-values? That is a standard.
Chances of exposure.
Dr. Somsha bro, I agree with the Dr. Ognishekhar. If there is a randomization, the distribution should have been, there will be some proportionate distribution in all three arms.
Madam, it's a by chance because the
because
number is short.
randomization, no,
If your number
randomization,
is a number
Yeah,
is a
it has
big
happened
one.
by chance. And I looked into how they have randomized. When I looked into their randomization protocol, that how they have actually randomized it, it is not there in the paper. It is there in one of the supplements. Yeah, and what they have done is called a process called dynamic allocation.
By computer,
by computer. Nowadays,
and that is a well accepted method actually.
Yeah, now everything is done by computer.
Yeah, dynamic allocation is a well accepted method.
If you can increase the study population, then this kind of problem will also get nullified, auto-nullified. I mean, this kind of bias is because.
And another thing, Dr. Shamsura, from my side, that they have taken just the preterm, whether there any other complications were there in the neonatal period, that was not mentioned.
No, madam.
Because that might lead to the lung functions. Moreover, no confounding factors.
They have accepted that the child has undergone some sort of BPD changes. They have undergone ventilation, oxygenation. That is taken into consideration.
At that time, should have been some scoring system or grade system. All children not having a same type of severity.
No, just to see, ma'am, this chart, they have mentioned everything. Who have got steroid, who have got ventilation, who got postnatal steroids. So ultimately, at the end of the day, this child have become healthy and they went into a healthy population. So maybe it's an eventful neonatal phase.
So what is the rationality to choosing the children between 7 to 12 years?
Because at that time
you can check them probably. FEV1
FEV1 can be done above 6 years.
It can be done.
Yeah,
up to 6 years.
6 years and above we can.
6 years and above it can be done. FEV1 can be done.
Yeah, and there is good amount of evidence that sort of BPD even in early neonatal life can have a persistent effect on your lung function test, even at this age.
Yes.
There is good evidence to say that.
So as they mentioned that the three limbs are equal at baseline. Have they mentioned this sentence like this? The three groups, the baselines are equal. Then the problem of Ogita may be solved because less number of less than 20 in each limb. So maybe there is some disparity of the weight, but they have not shown the calculated p-value, but they have might done by their own, and they have mentioned a line that all the three groups are similar in baseline. Have they mentioned such line?
No, they doesn't mention
p-value.
They didn't
mention. They just they can mention
baseline characteristics equivalent all groups lekha ki na kotha.
Is right. The randomized data we presume that all will be equal, but the sample size is smaller, so there can be a potential problem that is not with the randomization but the sample size. But if they mentioned, then the problem is not
they mentioned in the article clearly that after we have studied all the pre-intervention profile, it was more or less equally matched on all three arms.
Okay. Then that's
but it was not obvious. I mean, obviously, it was not as far as gestation goes.
Just to see
sample size difference but if the p-value is not much difference, then still we can interpret it that the sample size are equal and the
and it was random, so they could not help.
Sample size, but when some moved out from the trial, in this way, there's a distortion in sample size, and again they have to add lateral part. Initially, one thing I didn't mention that when the study was going on, they have a fresh assessment of the sample size. Initially, they thought it will be 60. Then they got actually 50. Then they adjusted to get a target standard deviation. of 10 in FEV1. For that, they had again included another 3 individuals from the control. So they made a.
That's why I'm asking. Debanjan was right. That sample size calculate how they have calculated. This is a ceiling study, probably a superiority study of LCS plus lava group. So during sample size calculation of 20, 20, 20 in each group, they might have got some data from some trial that may এত percent FEV success হয়, এই এত percent হয়। তো সেরকম কি study sample size আমি যদি
I am answering. Look, this kind of study, there was one study that is included beclomethasone and histamine probably. That study have failed to shown any superiority or any definite advantage. And prior to that, there was no such different study. So using that data, they have calculated this sample size.
Okay.
Okay, I think we have to move on. We have one more article. So if there are any more questions, please put in the chat boxes and we can ask Debanjan and Shomshubro to kindly address them. Debanjan, will you stop sharing? And Deblina, I hope we can start sharing your slides. Deblina, acho?
Yes, ma'am.
Okay, please start.
Yes,
So I'll just give a brief introduction of Dr. Deblina.
Yes, yes.
She is just sharing her slide. She did MD Pediatric from PGI Chandigarh, followed by she did her fellowship from Gangaram Hospital, FNB. Currently, she's working in ICH as the assistant professor. So she's going to present a very landmark study on antibiotic prophylaxis in viewer. So we know that UTI is a big problem in pediatric age group, and if it is associated with the viewer, that can complicate with recurrent UTI and scar formation. And if the scar is formed, then there is a long-term consequences like proteinuria, hypertension, hematuria, and even land up with the kidney failure. So there's a lot of strategies to examine for prevention of such complications. Among them, antibiotic prophylaxis is the important one. Majority of the guideline, they still recommend to use antibiotic prophylaxis in case of viewer, but it has some point against few studies also coming up against the antibiotic use. So it's a 2014 published article in NEJM that saying use of antibiotic in viewer. So Dr. Deblina, please, can you be able to share?
Before Deblina starts, Dr. Indranil Chaudhary has joined. Indranil, will you say a few words? Indranil, acha? Okay, Deblina, you have to go to the full screen mode. And if it's a problem, then you just start from here only.
Hello.
Yes, we can hear you.
তোমার স্লাইডটা মুভ করছে না, ইয়ে করে দেখো।
Shubhankar, actually, whenever I start sharing screen now, the Zoom system is crashing. So will you please share it from your screen and I can present?
Or you can put off your video.
You can answer, please.
Yeah, I have stopped sharing.
Okay.
Yes. Thank you, Shubhankar. Am I audible?
Yes, you got it. Go ahead.
So good evening, everybody. So now I'll start off with the second article of today's session. Move on to the next slide, kindly. Yeah. So the article we are going to discuss today is the RIVER trial titled Antimicrobial Prophylaxis for Children with Vesicoureteral Reflux. This was published in New England Journal of Medicine in June 2014. Next slide, please. So before we discuss the article, we have, I would like to shed some light on the background why this trial was conducted. So next slide. Yeah, so UTIs are common bacterial infections which are encountered in childhood, with 1 to 2% of boys and 3 to 7% of girls developing at least one episode of UTI during childhood, and recurrences are seen in nearly 30 to 50%. Nearly 30 to 40% of children who have a UTI can have an underlying VUR. So there were preliminary studies dating back to the 1970s to 1990s that showed that VUR, especially higher grade VURs, can predispose a child to recurrent UTI and renal scarring, and which can later on give rise to proteinuria, hypertension, progressive chronic kidney disease that can eventually result in end-stage kidney disease. Next slide, please. But later on, there were many studies that started coming up that actually challenged this hypothesis, because there were many children with high-grade VUR who did not have scar. Again, there were many children who had scarring and they did not have VUR or they did not develop UTI. Also, there were children, like there were small trials which had compared the efficacy of antimicrobial prophylaxis with no prophylaxis, and they found that there was no difference in the incidence of recurrent UTI or renal scarring, although these studies were underpowered. And also there were certain trials that had compared the value of antimicrobial prophylaxis with surgical treatment of vesicoureteric reflux, and those studies also failed to show any any significant difference in the incidence of recurrent UTI or in the incidence of renal scarring. Next slide, please. And then came the Cochrane meta-analysis in 2011 before the study was published, where they found that the use of long-term low-dose antibiotics tended to reduce the number of repeat symptomatic and febrile UTIs in children with VUR, but the result was not statistically significant. And even if it helped to decrease the incidence of repeat symptomatic and febrile UTI, but it did not help in reducing the risk of new or progressive renal damage. Although the prophylaxis produced few side effects, but there was a threefold increase in prophylactic drug resistance in subsequent UTIs. And all the RCTs which were included in this Cochrane meta-analysis, they were heterogeneous and there were many methodological flaws, like these studies were not adequately blinded, and there were other flaws also that predisposed to various kinds of bias. These studies were not adequately powered, and majority of these studies lacked a placebo arm. So next slide. So that's why the RIVER trial was conducted, to address the need for a well-designed, adequately powered study to address this, study this effect. Next slide, please. Next slide. So the objective was to determine, aim was to determine whether long-term antimicrobial prophylaxis is effective in preventing febrile or symptomatic recurrences of UTI and reducing the likelihood of renal scarring, and the extent to which it contributes to bacterial resistance. Next slide. So it was a multi-center randomized double-blind placebo-controlled trial that was conducted across 19 centers across USA. And it started enrollment in June 2007, that continued up till May 2011. And then there were another 2 years which were required to complete the follow-up. Next slide. So they included children who were 2 months to less than 72 months of age at the time of enrollment, at the time of randomization, that is less than 6 years of age. And all of them had first or second episode of UTI, not before 16 weeks from the time of enrollment. These UTIs had stringent diagnostic criteria, that is either there was fever more than 38 degrees Celsius, or there were symptoms related to urinary tract documented within 24 hours of the UTI workup. And these symptoms included dysuria, urgency, frequency, abdominal pain, foul smelling urine, and in infants, dehydration, hypothermia, and failure to thrive. And the index UTI, along with that, these symptoms, along with the symptoms, the child needed to have evidence of pyuria on urine analysis, which was defined as either more than equal to 10 WBCs per ml of uncentrifuged urine, or more than equal to 5 WBCs per high power filled in centrifuged urine, or leukocyte esterase more than TRES on dipstick. Along with that, there had to be proven culture with growth of single primary organism. Children who were toilet trained, in them the urine was collected by midstream clean cat specimen, and in that the colony count needed was more than equal to 10 to the power 5 CFU per ml. And if the child was not toilet trained, then the urine sample was collected by bladder catheterization or suprapubic aspiration, and that was defined as more than equal to 50,000 CFU per ml. All of this UTI had to happen within not more than 16 weeks or 112 days from the time of randomization. All the index UTI that resulted in the child being enrolled into the study had to be treated properly. So that was defined as having received more than 7 days of effective drug, or post-treatment, there had to be documentation of one negative urine culture, and all these children had undergone a VCUG that had demonstrated the presence of grade 1 to 4 VUR. Now, there were certain children they excluded. So what were the exclusion criteria? Any child having UTI more than 16 weeks from the time of randomization, any child who was having grade 5 VUR, any child who had 2 episodes of UTI before and the VUR had been diagnosed and treated in between the first and second episode. If any child had more than 2 UTIs prior to randomization, that child was excluded. If the index UTI was not treated adequately, or there were growth of more than 2 organisms, so then that was one exclusion criteria. Again, if the parent did not give consent, or if there were contraindications to giving cotrimoxazole, like presence of allergy, or even family history of anaphylactic reaction to sulfur, or if there were any medical conditions that were interfering with response to therapy, such as GI conditions like malabsorption, inflammatory bowel disease, liver failure, kidney failure, etc. And also, it excluded children who had comorbid urologic anomalies like dysplastic kidney, small kidney, etc., because there were chances that these children would have already had a scar. Again, any child with history of renal injury or disease, any child with any bladder or renal surgery were excluded. Any child having congenital or acquired immunodeficiency were excluded because obviously they were at increased risk of developing UTI later on. There was one exclusion criteria which I did not understand. That is, if any child was less than 6 months old, and if the child was born with a gestational age less than 34 weeks, and that child was also excluded. I could not understand why this was an exclusion criteria, nor did they give any explanation regarding this in any of the supplementary or the main article or associated articles they had published before the actual publication of this article. So if anybody else can shed a light, I will be grateful. So next slide. So after confirming eligibility, informed consent was taken. Once informed consent was taken, these children were subjected to randomization. So I would like to discuss a bit about the randomization process that was used. As I had told earlier, there were 19 centers across USA that were recruiting these children, and these 19 centers were heterogeneous in terms of the race, the ethnicity of the children enrolled, and also the level of care that was provided in each of these hospitals. So that's why they did a randomization which was stratified according to the recruiting center. And in each of the centers, they did a permuted block randomization. So why did they do a block randomization? Because in case there was a premature termination of the study due to any reason, block randomization ensures that the number of children enrolled in each of the study arm and the placebo arm, they are more or less comparable. And this was done according to a web-based system that generated the randomization sequence. So once the randomization was done, these study participants were assigned a uniquely coded bottle. So this bottle could contain either the study medicine or the placebo. And what it actually contained was blinded for everyone except for certain investigators at the Nodal Data Collection Center and also the medication bottling facility. And the study medicine was cotrimoxazole, that is trimethoprim plus sulfamethoxazole, and it was given at the dose of 3 mg per kg of trimethoprim and 15 mg per kg of sulfamethoxazole. Usually what happens whenever we are giving prophylaxis for UTI with cotrimoxazole, we give it at the dose of 2 to 5 mg per kg of trimethoprim. So they gave at 3 mg per kg because these children were actually given a study medicine for next 6 months before they were refilled. So if they are giving a dose of 3 mg per kg at onset, even if the child has weight gain, it will ensure that by the end of 6 months, it may come down to 2 mg per kg and they don't end up receiving underdose of the medicine. And the placebo and the study medicine, they were similar in color, taste, odor, consistency, and they were packaged in similar bottles. Next slide. So after randomization, there were baseline clinical data was collected along with certain blood investigations like serum electrolytes, creatinine and cystatin C to estimate the GFR at baseline. Urine analysis was done along with estimation of urine microalbumin creatinine ratio. Rectal swabs were sent to detect antimicrobial resistant E. coli or other pathogens in stool, and all children randomized had to undergo DMSA within 2 weeks of randomization and no later than 16 weeks after UTI. So these were what was done at study entry. Next slide. Along with this, the parents were also provided, as I told earlier, 6-month study medication or placebo. They were giving educational material for UTI and VUR, and there was ongoing counseling about the signs and symptoms for early diagnosis of UTI and prompt treatment initiation. So that helped in prompt detection and treatment of UTI. And they were also given diary for recording intercurrent fever symptoms, medication use, and medical care visits. Next slide. And follow-up were done 2 monthly with the help of telephone calls, which were meant to review the medical diary to ascertain whether there were any intercurrent UTI, any medical problem, to ascertain the medicine adherence. And these were followed by 6 monthly in-person visits where all of these were done. Along with that, the parents were also asked to complete surveys about dysfunctional voiding symptoms, constipation, quality of life, and a CBC was done to check whether cotrimoxazole was causing any bone marrow suppression. DMSA was done at 1 year and then at study exit. The study exit scan was called as an outcome scan. If, however, any child had treatment failure, which I will discuss later what treatment failure is, then in that case, they had repeated the DMSA 4 months after the UTI that classified that child as treatment failure. And in that case, that was considered as the outcome scan. And at the end of the study, all the children were subjected to DMSA, avoiding cystourethropography, and all investigations that were done at baseline, like serum creatinine, electrolytes, cystatin C, urine routine, urine microcreatinine ratio, and rectal swab. Next slide. So this slide is a bit blurry, but this is just to summarize how the entire thing happened. So there was a febrile or symptomatic UTI, then they checked whether eligibility criteria was being met. After that, if the child was eligible for the study, the study screening and baseline imaging were completed. That included a VCUG. Ultrasound had to be done within 16 weeks after UTI so that any structural anomaly, etc., could be ruled out. And this was actually one of the exclusion criteria. And then all children underwent DMSA. And then all these, after confirming the eligibility, the randomization, the baseline data collection, etc., were done. And after that, scheduled follow-up contacts every 2 month in telephone visits, every 6 month in-person visit. And in between, if the child had any UTI, then UTI evaluation visit. Then at the end of the study, at 24 months or treatment failure, well, like 4 months after treatment failure, they used to call it the exit point. Then again, the baseline data was collected along with specimen collection, VCUG and DMSA. Next slide. So the primary outcome measure was recurrence of febrile or symptomatic urinary tract infection. Secondary outcome measures were time to recurrent UTI, renal scarring assessed by DMSA scan, treatment failure, and development of antimicrobial resistance in stool flora. Next slide. So yeah, this is just to shed a bit of the light on the DMSA scan assessment. So there were actually 2 independent nuclear medicine specialists who were blinded to the allocation of these children, and they were asked to study the DMSA. And they had actually divided the entire kidney into 12 segments. And they used to grade the scarring according to the number of segments affected. So any child who was having more than 4 segment involvement or any child who was having global atrophy was classified as having severe scar. Next slide. And recurrent UTI was defined as any infection more than 14 days after the end of appropriate treatment of the index UTI or after obtaining a negative urine culture or if there was infection with a new organism. And treatment failure was described as 2 febrile recurrences of UTI or 1 febrile plus 3 symptomatic recurrences or 4 symptomatic recurrences over the course of the study, or if there was new or worsening scarring at 1 year compared to the baseline. Again, if any child, suppose at study entry had severe renal scar to begin with, they did not wait to get the DMSA done at 1 year. If the child had first recurrence of UTI, then within 4 months of that first recurrence of UTI, they had done the DMSA. And if the DMSA showed worsening scar, it was called as treatment failure. Next slide. So this was the scoring for bladder bowel dysfunction that they did. So initially, like for assessing bladder bowel dysfunction, one may go for tests like urodynamic study, uroflowmetry, etc. But obviously that will cause significant discomfort that may result in parents opting out of the study, and that will obviously entail further costs. So that's why they decided that, okay, they will go for only clinical scoring system to ascertain bladder bowel dysfunction. Next slide. And they had also assessed the children for presence of constipation, which was assessed by the Paris Consensus on Childhood Constipation Terminology group. So if more than equal to 2 of the following criteria were present in the previous 8 days, then the child was classified as having constipation. So that included frequency of bowel movement less than 3 per week, more than 1 episode of fecal incontinence per week, large stools in the rectum or palpable on abdominal examination, passage of large stool that may obstruct the toilet, display of retentive posturing, and painful defecation. And adherence was assessed with the help of weighing of the bottles at each in-person visit, and also by inquiring about medicine adherence during telephone call visits and also during in-person study visits. Next slide. And the protocol was approved by the Institutional Review Board and the NID Data and Safety Monitoring Board. So now coming on to the statistical analysis part. So considering that 20% of children in the placebo group during a 2-year follow-up period will go on to develop febrile or symptomatic recurrences, and taking 10% in the uroprophylaxis group to be considered as significant, keeping the study, the power of the study at 80% at a two-sided alpha level of 0.05, the sample size came out to be 300 children in each of the study group and the placebo group. Intention to treat analysis of recurrences was done, stratified for the centers using Cochrane-Mantel-Haenszel test. Time to event analysis was done and Kaplan-Meier curve was constructed, and significance was assessed with the help of stratified log-rank test. Cox proportional hazards models were used for univariate multivariate analysis, and Fisher's exact test was done to compare adverse events. So next slide. Coming on to the results. So this is just a flow chart of the study enrollment. So 10,871 children were assessed for eligibility, out of whom 9,445 were not eligible because many did not meet UTI criteria, many did not undergo VCUG, many did not have VUR, many had grade 5 VUR. So eventually 1,426 children were eligible, out of which 819 did not consent, 607 consented, and hence they underwent randomization. So that 302 were assigned to receive cotrimoxazole and 305 were assigned to receive placebo, out of which 247 were assessed at 1 year, 261 were assessed at 2 years in the cotrimoxazole group, and in the placebo group, 262 were assessed at 1 year and 259 were assessed at 2 years. In the cotrimoxazole group, 202 continued intervention, 76 discontinued intervention, and there were various reasons behind discontinuation of intervention. One of them being treatment failure, one being withdrawal by parents, one being study medication being stopped by parents, etc. And in the placebo group, 189 had continued intervention and 91 had discontinued intervention. So the major difference between the study group and the placebo group was mainly because of the difference in the rates of treatment failure. But nevertheless, intention to treat analysis was done, and all 302 who were randomized to receive the cotrimoxazole were analyzed, and also the 305, all 305 who were assigned to receive placebo were analyzed. So next slide. Okay, so this is a table showing the baseline characteristics. So the baseline characteristics across the two groups were similar. The median age of all the children enrolled were 12 months. Majority of them were females, nearly 92% were females, and majority, like 80%, were white. And majority were enrolled after first episode of UTI. 91% were enrolled after first episode of UTI, and 86% of children had febrile UTI with or without symptoms, and 80% had growth of organisms which were susceptible to cotrimoxazole. Out of the 607 children who were enrolled, 126 children were toilet trained, and out of them 71 had bladder bowel dysfunction. So 56.3% had bladder bowel dysfunction among the children who were toilet trained, and nearly 11% had grade 1 VUR, 42% had grade 2, and 38% had grade 3 VUR, and 8.3% had grade 4, and 47.8% had bilateral VUR. Next slide. And there was no significant difference in the reported adherence to the study medication regimen. And the adherence which was observed was also close to real life scenario. And it was found that 76.9% children had received the study medication at least 75% of the time, and 85.2% had received it at least 50% of the time. Next slide. Okay. So now it was seen that the number of febrile or symptomatic UTIs, the number of children with febrile or symptomatic UTI was 60 in the cotrimoxazole group, and in the placebo group it was 111, with a hazard ratio of 0.5 at the end of the study, meaning that the children under the cotrimoxazole arm were at 50% less risk of developing a febrile or symptomatic UTI than the placebo group. The 95% confidence interval for the hazard ratio was 0.34 to 0.74, and the difference in the incidence of febrile or symptomatic UTI was present, favoring the cotrimoxazole administration since the initiation of the study, and this benefit kept on increasing as the time progressed. Next slide. Okay. Now, as I told earlier, there were some children who were missing 2-year data, but since they did an intention to treat analysis, so they considered that these children with missing 2-year data did have symptomatic febrile or did have recurrent febrile or symptomatic UTI. So if they did that analysis, and it was found that 25.5% of the children in the cotrimoxazole and 37.4% children in the placebo arm had recurrent febrile or symptomatic UTI, and the absolute difference in risk was 11.9 and the relative risk was 0.68, with 95% confidence interval of 0.53 to 0.87. And the relative risk favored the cotrimoxazole even when the missing 2-year data, children with missing 2-year data were classified as having not had an event, and even when children with missing 2-year data were omitted from analysis. Next slide. Okay. They had even done a subgroup analysis based on the grade of VUR. So it was found that this benefit of giving cotrimoxazole over placebo was true in children with lower grade VUR, that is grade 1 to 2 VUR, and this benefit also existed, albeit a bit less, in children with grade 3 and 4 VUR. Next slide. Now the time to incidence of 10% recurrence in the prophylaxis group was 336 days. And 106 days in the placebo group. So yes, the prophylaxis group did take longer time to develop 10% recurrence, and 8 children with confidence interval of 5 to 16 had to be treated with prophylaxis over 2 years to prevent 1 episode of febrile or symptomatic UTI. Next slide. They had even done Cox proportional hazard model analysis. And although they did not mention how they anything about the 2 models, like how they had created the models, but that is not mentioned in any of the supplementary articles or in this article. But it was found that this hazard ratio favoring the cotrimoxazole treatment existed across both the models, with the hazard ratio being 0.49 with a confidence interval of 0.33 to 0.73 in model 1, and the hazard ratio being 0.44 with a confidence interval of 0.29 to 0.66 in model 2. And it was also found that children with higher grade of baseline VUR were at an increased risk of developing recurrent febrile or symptomatic UTI in both the models, and children who were enrolled after the second episode of UTI as compared to the first were at higher risk of developing recurrent febrile or symptomatic UTI, although this difference was almost it was almost going towards non-significance. Next slide. Regarding treatment failure, 5% of children in the cotrimoxazole group had treatment failure, and 9.6% of children in the placebo group had treatment failure, and this difference was statistically significant. However, children developing renal scarring overall or children developing severe scarring or new scarring during the course of the study, there was no difference in the incidence of these between the two groups, as is evident from the p-values. Also, they found that there was no difference in the number of children growing resistant E. coli in stool between the two groups. However, if we consider the incidence of resistant E. coli in the first recurrent febrile or symptomatic UTI, then it was definitely more in the cotrimoxazole group, 63.3%, as compared to the placebo group, 19.3%, with a p-value of less than 0.001. So yes, cotrimoxazole administration did result in higher incidence of resistant E. coli in the first recurrent febrile or symptomatic UTI. Next slide. Next. Yeah. They also tried to do effect modification. They tried to find out what are the various factors that can actually have an effect on modifying the hazard ratio. So they postulated that there can be various factors like gender, age, VUR at baseline, VUR at 2 years, index UTI, whether it was first or second, whether it was febrile, non-febrile, what was the resistance pattern in the index UTI, whether there was BBD present at baseline and constipation at baseline or during the study. They postulated that these are factors that may actually have an effect on the hazard ratio. So they did this analysis and they found that overall, the hazard ratio was actually favoring cotrimoxazole. When they did a subgroup analysis for gender, they found that it was favoring cotrimoxazole in the females, but not in the males. The hazard ratio remained in favor of cotrimoxazole irrespective of age. Again, the hazard ratio was more in favor of cotrimoxazole in grade 1 or 2 VUR, but not so in grade 3 or 4. And they also did not depend much on whether the VUR had improved or not improved at the end of study period. Also, the hazard ratio favored cotrimoxazole if the children were enrolled after first episode, but not after the second episode. And they also favored the cotrimoxazole if the children were enrolled after a febrile UTI rather than a non-febrile UTI. So, like they tried to find out what was the significance of interaction of all these factors in modifying the hazard ratio. They found that only two factors, that is whether the index UTI was febrile, non-febrile, or whether there was presence of BBD at baseline. These were the only two factors that actually modified the hazard ratio to a significant extent. Next slide. And there was no significant difference in adverse events reported between the two groups, and there was no significant difference in hospitalizations or emergency room visits between the two groups. Next slide. So to summarize the findings, antimicrobial prophylaxis in children with VUR diagnosed after a first or second UTI was associated with halving of the risk of febrile or symptomatic recurrences. Children with BBD at baseline and children whose index infection was febrile derived particular benefit from prophylaxis with reductions in recurrences of approximately 80% and 60% respectively. Next slide. Rates of renal scarring at the outcome visit were low and they were not reduced by prophylaxis. So they postulated maybe because most of the children were enrolled after the first infection, and also since the parents were vigilant about the so it was possible to diagnose and treat the UTI early. And recurrences that did occur in children who received prophylaxis were more likely to have been caused by a resistant pathogen. Next slide. So study limitations as discussed by the authors. They said that the study results may not be applicable to children with different demographic or clinical characteristics or children in locals where the susceptibility to cotrimoxazole may be different. And also they agreed that some subgroup analysis had limited statistical power. Next slide. So now coming to the critical appraisal. So we have used the CASP checklist for assessing this RCT. So first is the section A, where we see whether the basic study design was valid for a randomized control trial. So the first, did the study address a clearly focused research question? Yes, it did. It had a population which was children 2 to less than 72 months of age with grade 1 to 4 VUR enrolled after a first or second episode of UTI, febrile or symptomatic. Okay, ma'am. Okay. So yes, the study did address a clearly focused research question. Were the assignments of participants to interventions randomized? Yes. Were all the participants who entered the study accounted for at its conclusion? Yes, okay. And then comes the section B, where we assess whether the study was methodologically sound. So were the participants blind to intervention they were given? Yes. Were the investigators blind to the intervention they were given to participants? Yes. Were the people assessing, analyzing outcomes blinded? To a certain extent, yes, because those who were the nuclear medicine specialists and also the radiologists, they were blinded, but not all the assessors. So I would tell this is no. It was a double-blinded trial. Were the study groups similar at the start of the randomized control trial? Yes, as was evident from the baseline demographic and clinical characteristics. Apart from the experimental intervention, did each study group receive the same level of care? Yes. Next slide. So now regarding the results, were the effects of the intervention reported comprehensively? So power calculation was undertaken, outcomes were measured, and they were clearly specified. The results were expressed properly with expression of, like, whenever there were binary outcomes, they had shown the relative risk, they had shown the absolute risk difference. Results reported for each outcome in each study group at each follow-up interval, no, because they had only shed light on the incidence of febrile or symptomatic recurrent UTI at each study visit, but not about the scarring, but that was in any case not in the study protocol. Any missing incomplete data? Yes, they were there, but there was no differential dropout between the study groups that could affect the results. Potential sources of bias were identified and they were eliminated. And they had clearly indicated what statistical tests were used, and p-values were also reported. Now, precision of the estimate of intervention or treatment effect was also reported. Now, do the benefits of experimental intervention outweigh the harms and cost? They did specify the size of intervention or treatment effect. However, they did not do a cost-effective analysis. So I would say this was no. Next slide. Now, can the results be applied to our local population in your context? This I would say no. The study participants are not similar to the Indian children, because the basic difference between children, there are definitely certain racial and ethnic variations which can affect the incidence of scarring. That is one thing. Secondly, the children under who were enrolled in the RIVER trial, the parents were sensitized so that the UTI could be detected and treated promptly. That may not be so for majority of the children in India. Are the outcomes important to our population? Yes. Are there any outcomes you would have wanted information on that have not been studied or reported? I would say so, because they did not tell anything about the incidence of renal scarring according to the grades of VUR present, which they had actually done subsequently on another study, but not in this study. Previous slide, please. And are there any limitations of the study that would affect your decision? Yes, like these are the limitations that could affect my decision. And what would the experimental intervention provide greater value to the people in your care than any of the existing interventions? Yes, I would say so, because antimicrobial prophylaxis, if it is found to prevent UTI, that would definitely be helpful to the for the treatment of children in India. And like we follow this, like we are already treating children with antimicrobial prophylaxis. So next slide. So strengths of the study, I would say this was a well-designed study that helped in eliminating many bias, which was there in previous studies that were conducted till this study. And they had also included children 2 months to less than 6 years, which actually happens to be the most vulnerable age group for UTI due to VUR. And they had included all grades of VUR except grade 5, so making the results more generalizable. They had stringent UTI diagnostic criteria as compared to previous studies where they did not have stringent diagnostic criteria, and many were accepting back samples also. And adherence was checked, and it was found to be similar to that in reality. And DMSA findings, BCUG findings, USG findings, all were standardized. Next slide. I will just skip this slide because we don't have much time. Next slide. Limitations which I feel the study had, the study did not include a subgroup with no VUR. Secondly, the study also did not study the effect of other prophylaxis medications, because in areas where cotrimoxazole resistance is prevalent, in that case, other prophylaxis medications may be helpful. That was not studied in this trial. Also, the study was not powered enough to detect renal scarring. So although we said that there was no difference in the rates of renal scarring despite giving antimicrobial prophylaxis, but if the study is not powered to detect renal scarring, I don't think it will be right to generalize that finding. Secondly, we had only followed up these children till 2 years, and probably longer duration of follow-up would have been desirable to detect renal scarring. And again, as I said earlier, prompt diagnosis and treatment of UTI may not be the real life scenario in developing countries. Next slide. So take home message that I can find from this trial is that antimicrobial prophylaxis decreases risk of recurrent febrile UTI, but not necessarily scarring. So we need to carefully apply the study results in population like ours. And probably, although it says that antimicrobial prophylaxis may not help in, like I would like to draw attention to one particular finding of this study, where they had shown that the hazard ratio favoring antimicrobial prophylaxis was better when children with lower grades were considered as compared to children with higher grades of VUR 3-4. So probably it is also trying to say that in higher grades of VUR, antimicrobial prophylaxis may not that be helpful, but then it is time to think whether selective antimicrobial prophylaxis rather than umbrella cover with uroprophylaxis will be helpful. So I will end my presentation here and would like to answer the questions.
Shubhankar, comments?
So, okay, ma'am. Actually, Devina rightly says that before 2011, there have been few studies done, but all the studies was high risk and not bias free actually. After that, 2011, there is a few studies like Prevent trial, the River trial, followed by from the India, from the AIMS trial by Pankaj Hari. So after that study, these studies are very low risk, low bias study. And all these studies says that not routinely use of antimicrobial prophylaxis for all children with the VUR. So we need to stratify that those who are get benefit from the antimicrobial prophylaxis and those who are not. So from this study, we can say those who have recurrent febrile UTI with VUR, those who have bowel bladder dysfunction, unless until they are corrected, we can continue the prophylaxis rather than giving all patients with the recurrent VUR, recurrent UTI with VUR.
Yes, thank you. I think all of us have changed our practice somewhat, isn't it, to direct the continuous antibiotic prophylaxis to patients who, as you have said, are at higher risk. So there are some questions in the chat box, if either of you would like to take them.
Okay,
I think this is very important. What Shumantro has said, the two consequent studies, the River trial and the AIMS trial, the River trial had mostly girls and the AIMS trial had mostly boys. And they have very diametrically opposite findings, isn't it? So any comments about that?
Yes, ma'am. Actually, there was this beautiful publication by Dr. T.K. Mattu sir in CJSN in 2016. He had actually drawn a graph where he had shown that there were studies who were actually including more males. So in studies where there are more males, males are more likely to be having congenital scars and females are more likely to be having scars following a UTI. So if we try to in any study which is having more number of males, there the scars are already congenitally present. So how much effect there will be because of antimicrobial prophylaxis is questionable. Whereas in studies which are including more number of females, there we may see some effect of the positive effect of the uroprophylaxis medication.
Although this is not really looking at scars, these studies are looking at recurrence of UTI, isn't it?
Yes, ma'am. And this is also there, they say that in females, it was evident in this study also. Like when if I show that previous effect modification analysis chart, they had clearly shown that this hazard ratio favoring the cotrimoxazole was true in females, but not in case of males. So obviously, if we are including studies where more number of females are present, then in that case, my antimicrobial prophylaxis may show reduction in incidence of recurrent UTI. Whereas if I'm including more number of males in my study, I may see no difference. So why this happens, that I don't know. What is the basic pathophysiology behind this?
Okay, Shumantro, তুমি কি জিজ্ঞেস করবে your other questions?
Ma'am, more or less answer দিয়ে দিয়েছে. যেটা পড়া যেটা হচ্ছে এখানে একটাই পয়েন্ট ছিল যে 200টা বাচ্চা 600টার মধ্যে দে ডিসকন্টিনিউ দ্য মেডিসিন, স্টাডি মেডিসিন, either placebo or therapy. They are equal in both sides, I agree. But wherever this large amount of children discontinue the medicine or lost to follow up, সেখানটা ফ্র্যাজিলিটি ইন্ডেক্স বলে অনেক সময় থাকে। সাপোজ এই 100টার মধ্যে 90টা বাচ্চারই ইউটিআই হলো ইন সেপ্ট্রান গ্রুপ, আর 100টার মধ্যে 90টা বাচ্চারই ইউটিআই হলো না ইন প্লেসিবো গ্রুপ, সেক্ষেত্রে হয়তো ওই গোটা রেজাল্টটাই অন্যদিকে চেঞ্জ হতে পারে। তো তাই জন্য একটা ফ্র্যাজিলিটি ইন্ডেক্স বার করা হয়। সাপোজ এই পেশেন্টের 25টা, সাপোজ এক্সাম্পল 25 ইজ দ্য ফ্র্যাজিলিটি ইন্ডেক্স, 25টা বাচ্চা এই ঘর থেকে ওই ঘরে গেলে দ্য রেজাল্ট উইল বি জাস্ট অপোজিট ডাইরেকশন। তো ওইটা যেখানে ম্যাক্সিমাম নাম্বার অফ লস টু ফলো আপ হয়, সেখানে ইন্ডেক্সটা অনেক সময় অনেক আকৃতি দিয়ে দেয়। এখানে কেন দেয়নি খুব একটা জানা নেই। এনিওয়ে, আর বাকি তো
এই জিনিসটা আমি ওই সাপ্লিমেন্টারি গুলোতেও দেখেছি, এটা দেওয়া নেই কোথাও।
No, actually, these are the drawback of this study. So every study should have some drawback. I think these are the drawback that the trying to say that.
আর ডেফিনেটলি যেহেতু ছিল 6 মান্থের তলায় বাচ্চা কেন নেয়নি, প্রবাবলি ডিএমএস এ করাতে আপটেক অথবা সেপ্ট্রাম দেওয়াটা হয়তো একটু ডিফিকাল্ট ফর এ 34 উইকার্স, যার ক্ষেত্রে কারেক্টেড এজ তখন হয়তো 3 মাস বা 4 মাস হবে, হয়তো সেটা হতে পারে, আমি নট শিওর। সেই জন্য হয়তো ওরা বাদ দিয়েছে।
So other doing MCUG and the other procedure, the inclusion will be very difficult for that group actually. So and the development of the scar, it will take around few month, 3 months at least. No? So unless say antenatally diagnose, antenatally viewer and leads to CAR, this has some separate group. I think they has some separate prognosis. So that's why they try to exclude that part most probably. But we don't have that hard logic to
developmental scar হলে তো সেটা রয়ে যাবে, তাতে তো এজ গ্রুপ এক্সক্লুড করলে we cannot delete them. If it is a developmental scar, it will be valid for all age group of children. Plus even if এরা যেখানে acute DMS এ করেছে, মানে within 1 month, যেটা আমরা ইউজুয়ালি করি না, সেখানে ওরা মাত্র একজনকেই স্কার পেয়েছে। বেশিরভাগ স্কারটাই এদের কিন্তু পার্মানেন্ট স্কার। এটা ডেভেলপমেন্ট হতে পারে, ডিউটি উঠেই হতে পারে, দ্যাটস ডিফারেন্ট।
সুমন্ত্রদা, হ্যাভিং সেড দ্যাট, এখানে ওই ডক্টর টিকে মাটুরি ওই আর্টিকেলটাতে একটা জায়গাতে মেনশন ছিল যে দেখা গেছে যে যদিও many of these children at baseline may not have a scar, but many of them are having reduced percentage of uptake on DMSA. So whether
the stars become more evident with time.
Yes, ma'am. Yes, ma'am.
So 2 years follow-up really isn't enough in many of these cases.
Yes, ma'am.
Okay, let some non-nephrologists ask some questions.
Okay. Can I make some comment?
Yes.
Hello.
Ogni,
yeah, am I audible? Yeah.
Yes,
yeah. Number one, I absolutely loved Devlina's presentation. It took time, but I think that is what we should do. We should rather look into quality rather than quantity. We should go in depth and really study so that we know how to tease out things rather than going superficially. I absolutely loved it. Number one. Number two, Devlina, can you show me that forest plot like thing, the hazard ratio groups?
Yes,
can you have a look at that slide?
Yes, we can. Shubhankar, doctor. Actually, there were many statistical parts I could not understand.
For a phone call.
So I would really be grateful.
Sorry, can I have that? Can you have that?
Yes.
No. Yeah. This one. Can you enlarge it? Yeah. And there, if you look at the BBD at baseline thing, you have already sort of circled it. Yeah, that one. So if it is present, then your hazard ratio is fine. It's much less than 1 and it's hunky-dory. It is not touching your 1 and it's very good. It looks fine, good. And we know if there is BBD at present there, then it really works fine. That's good. Look at the other one where it is absent. There, your hazard ratio is 1.4. It is more than 1. So at least statistically, it seems that if you do not have BBD and you are put on prophylaxis, then the risk of developing some infection subsequently is more than if you are on placebo. At least statistically, that is what it tells me.
Yes.
But the hazard ratio is 1.4.
Not more. Sir, another thing we
not more.
This subgroup
it's 1.4. It's more than 1.
Yes,
crossing
absolutely,
1, isn't it?
Absolutely true.
No, it is crossing 1, but even the point is on the other side of the line.
But
But it
still,
The
is
hazard ratio is 1.4. So
Correct. If that touches the line, then it means it is not
it doesn't,
significant. It is
no
high
It's not
difference.
chance.
so look,
significant.
if it is
There is no
touching the
difference. Yeah,
line,
it is
if
not
it is
difference.
crossing the line, then it is not significant.
Yes.
If it
Not
is
significant.
crossing
Correct.
the
So that's
line,
why
then
we
it is
don't
not
give,
significant.
if there is no BVT, we usually don't advise prophylaxis also.
So
পরের দিকে
actually,
একটা
that's
high
the
হয়েছে,
concept is
এটাতে
coming up
hazardous
right
বলা
now.
যাবে না. We cannot tell hazardous. We can tell
So-
not significant.
So actually,
Yeah. Well, okay, yeah, yeah, because it is
And
not
we
significant.
have to keep
but
one thing in mind, that the subgroups were the subgroup analysis was not adequately powered.
Powered. True.
So this whole thing could change if we had many
Yes.
more patients with
Yes,
BBT.
Yes.
Correct.
Yeah, I
BVT
found
নেই,
that
এরকম
quite
মাত্র
remarkable.
35%.
Uh,
So the number is quite less.
Yeah, true. The power was not great. Yeah, sure.
So
Thank
that's why
you.
the conclusion is coming that if the child with viewer with bowel bladder dysfunction in present, so that's suggests to use antibiotic prophylaxis.
And it is also suggesting that if you give them, then you may actually causing some harm, maybe. I mean, at least that is the message to
In
me.
form of resistance. In form of resistance.
Yes, that's a concern actually.
So basically, the final take home is that when we are giving continuous prophylaxis, we need to balance these two arms. The positive side may be that we will prevent further infections. Negative side is we may cause resistance to whatever prophylactic agent we are giving. So I think these are the two issues that we have to balance and then decide from patient to patient who to give prophylaxis to.
Okay, ma'am, so we have few questions from Dr. Shutaba ma'am is saying that use of probiotic in prophylaxis against recurrent UTI. So I don't have knowledge about the such prophylaxis. I think people have used or not, but
So
still
I have just looked up recently, treatment, antibiotics and probiotics and things. So the end point is that if you give prophylaxis along with probiotics, then it is better than giving prophylaxis alone. But according to the reviews. But if you give prophylaxis, the probiotics alone, then it is not effective. That is what the study so far shows.
there's some
There are some RCTs also, even if there is a meta-analysis also on probiotics and versus this one. Unfortunately, meta-analysis from our team. So তাতে বলে আমরা দেখেছি যে antibiotic prophylaxis versus probiotics versus cranberry, all are equal and all the three are individually equal and all the three are superior to placebo, but all the children are with normal urinary tracts with recurrent UTI. এই যদি এই প্রোফাইলের পেশেন্ট হয় তবেই এর ক্ষেত্রে প্রোবায়োটিক্স আমরা প্রেফার করতে পারি। অ্যাডভান্টেজ হচ্ছে the cranberry and the probiotic part has added advantage of less antibiotic resistance compared to the prophylaxis. But all three are better than placebo group, at least in the meta-analysis. It is a 2021 variation. You can read the summary.
Actually, the probiotic is a now controversial topic is coming in next decade, I think so. Everybody is using probiotic in everywhere and nobody knows what the benefit, like zinc, vitamin D, now the probiotics era is coming actually. So it will take another decades to conclusion for probiotic use or not, because the probiotic lot of question to be answered.
But at least meta-analysis তাই বলছে।
What kind of probiotic and what kind of dose and everything, because it's very diverse. It's not the specific things. Lot of variable parameter is there for use of probiotic. Okay, so next question from Maya madam, that only one antibiotic prophylaxis has been considered. What about the others? So I think the study population where the study is done, the antibiotic choice is like cotrimoxazole, and it drug is very sensitive there for use as a prophylactic agent, rather than in our country we don't know the resistant pattern. That's true for choosing that drug actually. And for the making the similarity intervention, if you use multiple antibiotic prophylaxis, that will be more, I mean, the assessment will be the difficult and randomization will be the problem. That's the things actually. And Devilona, you want to add anything regarding the comment?
Actually, they selected cotrimoxazole because they had done some pilot studies and they found that more than 80% of the isolates were susceptible. So probably that was the reason. And they did consider that cotrimoxazole in certain cases can cause Stevens-Johnson, they can cause G6PD deficiency, but the chances of those side effects are very less as compared to, like, they had done a cost-effective analysis also. So in that case, that favored administration of cotrimoxazole as a uroprophylaxis.
Okay, any questions from anybody?
Just a comment, prophylaxis সেফট্রান বা নাইট্রোফিউরান্টনের মতো সবসময় ন্যারো স্পেকট্রামই দিয়ে রাখা উচিত ইন কম্পারিজন টু সেফালাক্সিন বা অফ্লক্সাসিন লো ডোজ, যাদের ক্ষেত্রে স্পেকট্রাম একটু ওয়াইডার, আনলেস বাচ্চা খুব ছোট 3 মান্থস বা এই এজ গ্রুপ, ইউজুয়ালি সেফট্রান বা নাইট্রোফিউরান্টন থাকতেই বেটার। লোকাল সেন্সিটিভিটি অবভিয়াসলি ম্যাটার করবে, তবে একটা ডিকটাম থাকে যে যদি একবার ইউরিনারি ইনফেকশনে রেজিস্ট্যান্স টু সেফট্রান পাওয়া যায়, after then also we can still put the patient on Ceftriaxone prophylaxis. This is a dictum, at least for one UTI. Recurrent UTI, we need to change the antibiotic, otherwise we can keep the patient still on Ceftriaxone if he has got one UTI that is resistant to Ceftriaxone.
Yes, sir. Actually, they did consider using nitrofurantoin as the backup uroprophylaxis, but then because of certain cost issues and because of certain study design issues and everything, they thought it will be cumbersome. That's why they stuck to only cotrimoxazole.
For non-nephrologists like us, is there any guideline or anything from any body which is stating that these are the group of kids where you should give prophylaxis and these are the groups where you should not? Is there anything from
so the ISPN has regularly been updating its guidelines. Unfortunately, the last guidelines are a little bit old, I think 2011. So there is another guideline actually being processed and will be out sometime this year. So you will be able to access it. The older guidelines, 2011, you can access. It's open access. Anyone is able to avail it. And it has, I think the groups it has advised CAP in are still quite valid actually today.
What are those groups? I mean, rather, I'm being lazy rather than going through the guideline. If I can get it.
So things like recurrent UTIs, recurrent febrile UTIs, high grades of reflux. With lower grades, it tells you that you continue CAP for a shorter period of time, with higher grades for a longer period of time. BBD. Anything else? Can anyone else?
Divided like low reflux group 1 to 2, grade 1 to 2.
1 to 2 is for 1 year, I think.
Yes, you
and our higher is for.
If you don't have any UTI between the years, you can stop the prophylaxis. But if child has recurrence of reflux during the prophylaxis, you can consider continue few years actually. But in the higher grade,
Sumantra, like, এক সেকেন্ড শুভঙ্কর
শুভঙ্কর
না
বলো
সুমন্ত্র নতুন যে গাইডলাইনটা হয়েছে, ওই নতুন গাইডলাইনে কিছু চেঞ্জ হচ্ছে?
আমি পুরোনো গাইডলাইনটা বলে দিন, যেটা ডক্টর অগ্নিশেখর দাদা স্যার বলতে চাইছে, শুনতে চাইছে। সো যদি
অগ্নিকে আমরা পাঠিয়ে দেবো।
হ্যাঁ। So I think it's basically shown very nicely in the river trial also. The VUR, the BBD, the ones with recurrent febrile UTIs. These are the high risk groups which we will, I think all of us, we still prescribe CAP in. Taito?
I think, ma'am, I may be wrong, but the previous ISPN guideline of 2011 still holds true, because when I was reading up all the articles, the way they have stratified according to the risk factors, I think it still holds true, and it will be interesting to see what new modifications they are going to come up with, like how much change is going to be there.
Yeah.
So we have another question actually that not related to the viewer, Dr. C.K. Ghosh. I just the question is like that: if recurrent UTI after first using most sensitive drug in full course, then the second sensitive drug can be used or not? So how will you interpret the question? I mean, he want to say most likely if I use first sensitive antibiotic for the first episode, can I use the second second sensitive drug in the second episode of UTI?
আমি ঠিক বুঝতে পারছি না কোয়েশ্চেনটা। চন্দ্রকান্ত দা থাকলে একটু বলুন না, কি what do you mean exactly? Do you mean antibiotic prophylaxis, যে যদি রেজিস্ট্যান্ট হয়ে যায় তাহলে আমরা চেঞ্জ করব, নাকি রিকারেন্স হলে চেঞ্জ করব? Sorry, I didn't understand the question. I don't think he's here anymore anyway.
Ma'am, Sarah generalization, first UTI sensitive to ceftriaxone, given 10 days of ceftriaxone, culture
Right.
is negative. Again, a
Right.
second UTI, again E. coli, again sensitive to ceftriaxone and ofloxacin, this time ceftriaxone or ofloxacin. Probably,
সেনসিটিভ থাকে তাহলে সেফট্রাক্সজনই দেওয়া যেতে পারে।
Correct.
If it is
And
very
try to find out more important is
কেন
why
কেন
recurrence
ইউটিআই হচ্ছে?
কেন recurrence হচ্ছে?
আরেকটা অপশন ভাবা যেতে পারে যে child is need admission or not, because if you choosing ceftriaxone multiple times you need to admit the child for IV.
হ্যাঁ হ্যাঁ, ওরাল অ্যান্টিবায়োটিকই হয়ে যাবে।
Yeah, that may be the very reason to use it actually.
এটা রেকর্ড হচ্ছে। আর একটা হচ্ছে কি that মানে আমার পার্সোনাল প্র্যাকটিস হচ্ছে কি that most of the like we miss BBT and this in NEGM study also highlighted that bowel bladder dysfunction is one of the very important cause, and this is something that we miss in our day-to-day practice.
ঠিক আছে, it's 9:45. Shall we draw this to a close? Shom Shubhro ki ache ekটু few words at the end bolbe? Shom Shubhro to acho?
Hello,
হ্যাঁ বলো।
am I audible?
হ্যাঁ হ্যাঁ।
Okay, it's an excellent presentation by Devlina and both Devanjan. And it took a lot of time, about more than close to 2 hours. So I think from next time we have to, it's possible to make it shorter, because I have seen more and more viewers, they are skipping the show now.
True,
We are just
true,
25 participants. Initially it was 55.
Maybe we should
So-
just do one article. I mean, two article, that too, you know, quite complicated. We
Yeah.
should do one and do that in depth.
In depth. Yes, that's a fine idea.
I think both the topic is very
It's difficult to find one topic that will interest everyone. সেই জন্য একটু ভ্যারাইটি রাখার জন্য দুটো টপিক রাখা হচ্ছে। But certainly আরেকটু maybe 1.5 hours aim করে তারপর একটু টাইমিংটা একটু খেয়াল রেখে বলতে হবে এরপরে।
Yeah.
ঠিক আছে? Thank you
Okay.
so much সবাইকে
Thank
for
you.
your
Thank
efforts,
you all,
for
thank you
to the
all.
audience for staying with us for so long.
Okay.
good night.